Imagine, for a moment, that you are waking up on a Tuesday morning. The sun is streaming through the blinds, and for a split second, you feel normal. But then, you move your leg. A sharp, burning sensation, distinct from a muscle ache or a bruise, shoots up your calf. You pull back the sheets, and there they are. Purple spots. Not just a few. Dozens of them. Some are the size of a pinhead, others have merged into angry, violet blotches that feel raised to the touch. They don't just look alarming, they hurt. They itch with a deep, maddening intensity that scratching cannot reach. You look at your ankles, and they are swollen, the skin tight and shiny. You rush to a mirror. You check your arms. More spots. You check your torso. You are covered in a map of inflammation. This is not an infection. It is not an allergy to your laundry detergent. This is your own body, your own immune system, turning its weapons against the very infrastructure that keeps you alive, your blood vessels. You go to the doctor. You expect a swift answer. You expect a standard protocol, a take 2 of these and call me in the morning solution. But instead, you are met with hesitation. The doctor looks at the spots, what they call palpable purpura, and they nod slowly. They tell you that you have cutaneous vasculitis. Inflammation of the skin's blood vessels. You ask, okay, how do we cure it? And this is where the story takes a dark and frustrating turn. Because the doctor looks at you and says, well, we can try this drug. It's an old gout medication. Or, we could try this antibiotic used for leprosy. Or maybe this immune suppressant used for organ transplants. We don't actually know which one is best. We're just going to guess and see what happens. Welcome to the medical Wild West of isolated skin vasculitis. For decades, millions of patients have been trapped in this cycle of trial and error, subjected to treatments based on hunches rather than hard data. But right now, at this very moment, a massive scientific machine is turning to change that forever. Today, we are going deep into a landmark study that is currently rewriting the rulebook for this condition. It is a trial with a design so sophisticated, so complex, that it mimics the chaotic reality of treating a human patient better than almost any study before it. It is a race between 3 of the oldest, most powerful drugs in our arsenal, pitting them against each other in a battle for supremacy. This is the story of the randomized multicenter study for isolated skin vasculitis trial. And by the end of this video, you will understand not just the future of skin disease, but the future of how we determine what medicine actually works. Welcome to my channel, Clinical Trials Explained. Before we can appreciate the brilliance of this study, we have to understand the battlefield. We have to understand what is actually happening beneath the surface of the skin when a patient develops isolated cutaneous vasculitis. Let's zoom in. Way in. Past the visible layer of skin, down into the dermis. Here, you have a vast network of capillaries and venules, tiny blood vessels that act as the plumbing system for your skin cells. In a healthy body, these pipes are smooth, flexible, and watertight. They deliver oxygen and nutrients, and they whisk away waste. But in vasculitis, a false alarm is triggered. Your immune system, specifically a type of white blood cell called the neutrophil, gets a signal that there is an invader. But there is no invader. The signal is a ghost. Neutrophils are the first responders of the immune system. They are aggressive. They are armed with toxic granules designed to dissolve bacteria. When they arrive at these tiny blood vessels in the skin, they don't find bacteria. But they are programmed to attack, so they attack the vessel walls themselves. They release enzymes. They release free radicals. They physically burrow into the wall of the blood vessel. This process has a terrifying name, leukocytoclastic vasculitis. Leuko means white blood cell. Cytoclastic means breaking or destroying. Literally, it means white blood cells exploding the blood vessels. When the vessel wall breaches, red blood cells spill out into the surrounding tissue. That is the purple spot you see. It's a tiny hemorrhage. But unlike a bruise, which heals and fades, the inflammation here keeps the wound open. The tissue around it starts to die. This can lead to open ulcers, profound pain, and a risk of severe infection. Now, here's the crucial distinction that defines the study we are discussing today. Vasculitis can be systemic, meaning it attacks the kidneys, the lungs, or the brain. That is life-threatening and requires aggressive chemotherapy-like drugs immediately. But for a huge number of patients, the war is limited strictly to the skin. This is isolated skin vasculitis. You might think, oh, that's good, at least it's not in the kidneys. And while that is true, it presents a different kind of nightmare. Because it is not immediately fatal, it is often dismissed as just a skin condition. But for the patient, it is chronic misery. It is legs that throb so much you can't walk. It is open sores that won't close for months. It is the psychological burden of looking like you have a plague. And because it hasn't been seen as a killer disease, science has neglected it. We haven't had big, expensive pharmaceutical trials to find the perfect cure. Instead, doctors have relied on 3 very old, very different drugs. Drug number 1, colchicine. An ancient remedy derived from the autumn crocus flower, used to treat gout. Drug number 2, Dapsone. A sulfur-based drug that was originally developed to fight leprosy in the 1940s. Drug number 3, Azathioprine. A heavy-hitter immunosuppressant used to prevent organ rejection in transplant patients. Here is the problem: if you walk into a clinic in New York, you might get colchicine. If you walk into a clinic in London, you might get Azathioprine. If you go to Tokyo, maybe you get Dapsone. Nobody knows which one works faster. Nobody knows which one is safer. Nobody knows which one keeps the disease away longer. It is a roll of the dice. And when you are in pain, you do not want to roll dice. You want a plan. This brings us to the centerpiece of our story, the ARAMIS Trial. The acronym stands for a randomized multicenter study for isolated skin vasculitis. It is funded by the National Institutes of Health and spearheaded by the Vasculitis Clinical Research Consortium. The purpose of this study is deceptively simple: to finally, after decades of guessing, determine which of these 3 standard drugs is the champion. But the researchers faced a massive problem when designing this study. In the real world, patients don't just take a drug and stay on it if it doesn't work. If you take a pill for 2 months and you still have purple spots, you stop taking it and try the next one. Standard clinical trials are terrible at modeling this. Usually, a trial compares drug A versus a sugar pill. If drug A fails, the patient is just marked as a failure and dropped from the data. That doesn't help a doctor make a decision. A doctor needs to know, if drug A fails, what do I do next? Is drug B the better backup, or drug C? So, the brilliant minds behind ARAMIS did something different. They used a design called a Sequential Multiple Assignment Randomized Trial, or SMART. Think of it like a tournament bracket or a choose-your-own-adventure book. Here is how it works. The study aims to enroll roughly 90 to 100 participants. These are people with proven, biopsy-confirmed vasculitis of the skin. They cannot have any organ involvement, no kidney failure, no lung issues. Just the skin. When a participant enters the study, they enter stage 1. They are randomly assigned, like flipping a coin, to one of the 3 drugs, colchicine, dapsone, or azathioprine. They take this drug for up to 6 months. Now, this is where it gets interesting. The researchers are watching like hawks. They are measuring success using a very specific set of rules. They are looking for a response. A response isn't just feeling better. It is defined rigorously. It means no new skin lesions. It means the old lesions are healing. It means the pain score has dropped. If the patient succeeds in stage 1, if the drug works, great. They stay on it, and the researchers track how long they stay in remission. But what if it fails? What if the spots keep coming? What if the side effects are too strong? In a normal study, that patient goes home. In the ARAMIS SMART design, that patient is immediately re-randomized into stage 2. If they failed on colchicine, they get switched instantly to either dapsone or azathioprine. If they failed on Dapsone, they get switched to Colchicine or Azathioprine. This is revolutionary because it builds a roadmap. It allows the researchers to say, okay, maybe Dapsone isn't the best first choice, but it is an incredible rescuer for people who failed Colchicine. It answers the question of sequence. Medicine is rarely a one-shot sniper rifle, it is often a game of strategy. ARAMIS is trying to solve the strategy. To truly understand the stakes for the participants, we need to understand what these drugs actually do to the human body. Because while they are all anti-inflammatory, they work in completely different, fascinating ways. Let's look at contender number 1, colchicine. Colchicine is a biological relic. We have known about the plant it comes from, the Colchicum autumnale, since ancient Egypt. It works by freezing the skeleton of the cell. Inside your white blood cells, those aggressive neutrophils we talked about, there are tiny structural tubes called microtubules. The cells use these tubes to move, to crawl towards the blood vessels. Colchicine binds to these tubes and breaks them apart. It literally paralyzes the white blood cell. If the neutrophil can't crawl, it can't reach the skin vessel. If it can't reach the vessel, it can't explode. It is an elegant mechanism. But it comes with a cost. Colchicine can irritate the gut. Severe diarrhea and nausea are common. The study has to monitor this carefully. Now, contender number 2, Dapsone. Dapsone has a heavy history. It changed the world by curing leprosy. But in vasculitis, we aren't using it to kill bacteria. We are using it to calm the storm. Dapsone interferes with an enzyme called myeloperoxidase. This is one of the chemical weapons the neutrophil uses to damage tissue. By inhibiting this weapon, Dapsone essentially disarms the soldier. But Dapsone has a very specific, genetic risk. It puts stress on red blood cells. If a patient has a genetic condition called G6PD deficiency, which is common in people of Mediterranean, African, or Asian descent, Dapsone can cause their red blood cells to burst. This is why the ARAMIS trial has strict inclusion and exclusion criteria. Before anyone gets Dapsone, they must be screened for this enzyme deficiency. It is a perfect example of how safety protocols are woven into the scientific method. Finally, contender number 3, Azathioprine. This is heavy artillery. Azathioprine is a purine synthesis inhibitor. Let's break that down. To make new white blood cells, your body needs DNA. To make DNA, it needs building blocks called purines. Azathioprine is a fake building block. It sneaks into the DNA factory and gums up the gears. The result? The body stops producing so many new white blood cells. The army of attackers is depleted. This is very effective, but it is slow. It can take months to reach full power. And because it suppresses the whole immune system, it raises the risk of infections. So, the trial is asking a complex trade-off question: is it better to paralyze the existing cells quickly with colchicine? Disarm them with Dapsone? Or stop them from being born with Azathioprine? Now, you might be asking, this sounds great, but what are the results? Who won? Here is the reality of clinical research, and it is important to be transparent about it. The ARAMIS trial is a long-term, ongoing slog. The estimated primary completion date extends into 2028. However, the reason we are talking about it now is because the lack of results is what makes the situation so desperate. We do have some clues from the past, and they are shocking. In 1995, a small study looked at colchicine versus a placebo for this condition. Do you know what they found? They found no difference. Statistically, the drug that everyone prescribes didn't perform much better than a sugar pill in that specific small group. And yet, doctors still prescribe it. Why? Because in the real world, doctors see anecdotal success. It worked for Mrs. Smith, so I'll try it on Mr. Jones. The ARAMIS trial is designed to destroy that ambiguity. The primary outcome measure of this study is response to therapy at month 6. But let's visualize what that data will look like when it finally drops. Imagine a chart. On the left, we have the success rate of colchicine. Maybe it is 60%. On the right, azathioprine. Maybe it is 75%. If azathioprine wins, it changes global guidelines. Suddenly, every dermatologist in the world stops starting with colchicine and starts with azathioprine. It saves patients weeks of pain. But the researchers are also measuring secondary outcomes that are just as vital to the human experience. They are measuring the time to flare. This is critical. Even if a drug clears up the spots, do they come back 2 weeks later? They are using the Skindex 29. This is a quality of life questionnaire. It asks questions like, how much does your skin condition affect your social life? Does it make you depressed? Does it stop you from working? By correlating the biological data, the spots, with the sociological data, the feelings, the ARAMIS trial acknowledges that curing the skin is only half the battle. You have to heal the patient's life. They are also doing something technically fascinating, genomic analysis. They are collecting blood samples to look at the RNA, the genetic messages, inside the patient's blood cells. They are trying to find biomarkers. Imagine if, in the future, you could walk into the doctor's office, get a blood test, and the computer says, based on your genetic profile, you will fail on colchicine, but you will respond perfectly to Dapsone. That is the ultimate goal. Personalized medicine. Eliminating the guesswork entirely. The ARAMIS trial is building the dataset to make that possible. We have to talk about safety. No clinical trial is without risk, and no drug is harmless. In this study, the safety monitoring is intense. For patients on azathioprine, the researchers are constantly checking liver function and white blood cell counts. If the white blood cells drop too low, a condition called leukopenia, the patient becomes vulnerable to pneumonia or sepsis. The trial has built-in stopping rules to catch this before it becomes dangerous. For patients on Dapsone, they are watching for hemolysis, the breaking of red blood cells, and methemoglobinemia. That is a condition where the hemoglobin in your blood changes shape and can't carry oxygen efficiently. It can literally turn a patient's blood chocolate-colored and make them short of breath. These risks sound scary. But in the context of a controlled trial, the patient is actually safer than in standard care. In standard care, a patient might take a pill and not see a doctor for 3 months. In the ARAMIS trial, they are being monitored by world-class experts with frequent check-ins. So, why does this matter to you? Why does a trial about purple spots on the legs matter to the world? Because cutaneous vasculitis is a window into the broader world of autoimmune disease. The mechanism, the body attacking itself, is the same mechanism behind rheumatoid arthritis, lupus, and Crohn's disease. By understanding how to manipulate the immune system in the skin, which is easily accessible and visible, we learn lessons that apply to the deep organs. If we learn that Dapsone is superior at stopping neutrophil attacks in the skin, it might lead researchers to re-evaluate its use in other neutrophil-driven diseases in the lungs or kidneys. Furthermore, the ARAMIS trial champions the smart design. This statistical method is the future of medicine. We are moving away from simple A versus B comparisons. We are moving towards dynamic, adaptive trials that treat patients like complex individuals, not static data points. As we wait for the final data from the ARAMIS team, likely to arrive in the late 2020s, we can take comfort in one thing: the era of guessing is ending. For the patient waking up tomorrow with burning, purple skin, the road is still rocky. But thanks to the hundreds of volunteers enrolling in this study across North America and beyond, the map is being drawn. They are enduring the blood draws, the biopsies, and the uncertainty of randomization not just to heal themselves, but to ensure that the next generation of patients doesn't have to suffer in the dark. Please remember that I am a communicator of scientific research, not a doctor. The information presented here regarding the ARAMIS trial, the drugs colchicine, Dapsone, and azathioprine, and the nature of vasculitis is for educational and informational purposes only. It is not medical advice. If you or a loved one are suffering from skin rashes, pain, or symptoms resembling vasculitis, do not attempt to self-medicate based on this video. Seek professional medical attention immediately from a board-certified rheumatologist or dermatologist. Clinical trials like ARAMIS are conducted under strict supervision that cannot be replicated at home. Science is often slow. It is often frustratingly complex. But it is the only candle we have in the dark. The ARAMIS trial represents the best of that spirit, a rigorous, methodical, and deeply human effort to turn the chaos of disease into the order of a cure. Thank you for listening to this deep dive into the world of clinical research. If you found this valuable, keep asking questions, keep seeking knowledge, and stay curious.